Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Selamat siang kepada teman-teman sekalian. Selamat datang di SYMPO 9 dengan tema Cardiac Imaging Protocol Update. Untuk memulai acara pada hari ini, saya akan bacakan CV singkat dari moderator yang akan membawakan acara pada hari ini. Moderator yang akan membawakan acara pada hari ini bernama Desi Ayu Komalasari. Riwayat pendidikan terakhir yaitu D3 Akper Pemprov Kaltim dan sekarang bekerja di instalasi kedokteran nuklir RSUD Abdul Wahab Syahrani sejak tahun 2018. Mungkin sekian CV singkat dari moderator. Untuk selanjutnya saya serahkan kepada moderator untuk melanjutkan acara. Terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Oke. Selamat siang semuanya. Salam sejahtera bagi kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan. Perkenalkan, nama saya Desi. Saya sebagai moderator untuk siang hari ini. Hari ini kita ada 2 pembicara. Untuk yang pertama, waktunya 20 menit dan nanti sesi tanya jawabnya 10 menit. Cuma ini karena untuk pembicara kedua belum datang, kemungkinan nanti setelah pembicara pertama selesai mungkin kita langsung buka sesi tanya jawab untuk mempersingkat waktu kita ya. Untuk pembicara pertama kita, Nurse Yunice Sitomorang, dia lulusan dari Universitas Pelita Harapan Tangerang tahun 2020. Dia sudah bekerja di kedokteran nuklir MRCCC Jakarta sejak 2021 sampai dengan sekarang. Ya. Untuk mempersingkat waktu, saya panggilkan pembicara kita, Mbak Yunice, boleh silakan ke depan untuk membawakan materi.
Baik, selamat siang sebelumnya. Di sini saya akan menjelaskan tentang judul yang diberikan oleh panitia yaitu The Role of Nursing Management in Cardiac Stress Test, The Challenge and Experience. Boleh. Baik, untuk sebelumnya kita akan membahas sekilas tentang apa itu sidik perfusi miokard. Sidik perfusi miokard itu sendiri adalah tindakan pemeriksaan non-invasif yang digunakan untuk mengevaluasi aliran darah ke otot jantung atau miokardium dan fungsi jantung secara keseluruhan. SPM ini biasanya dilakukan dengan penggunaan terapi radionuklida. Indikasi untuk sidik perfusi miokard atau SPM ini sendiri adalah dengan pasien suspek CAD atau sudah positif CAD, pasien dengan nyeri dada yang dicurigai PJK atau penyakit jantung koroner, infak miokard dan deteksi PJK pada LBBB. Terus kan ini challenge and experiment dari MRCC. Jadi saya akan menjelaskan lebih ke sharing tentang tindakan SPM yang dilakukan di MRCC. Tindakan SPM sendiri itu ada 2 penggunaannya, yaitu farmakologi dengan latihan fisik. Farmakologi sendiri ada dobutamin, dopamin, dan adenosin. Sementara latihan fisik itu ada sepeda statis dan treadmill. Dan yang sering dikerjakan di sana itu adalah dengan dobutamin, adenosin, dan juga dengan treadmill. Baik, secara sekilas juga saya akan menjelaskan tentang stress test dengan latihan fisik. Untuk stress test latihan fisik sendiri, ada sebelum tindakan ada persiapan yang khusus yang dilakukan oleh pasiennya, yaitu untuk menghentikan golongan beta blocker, obat-obatan golongan beta blocker dan golongan nitrat kurang lebih 48 jam dan menghentikan kafein kurang lebih 24 jam. Setelah persiapannya telah dilakukan, pasien datang dan melakukan tindakan SPM. Untuk pertama sekali akan dilakukan pengkajian oleh perawat tentang riwayat jantungnya, pengobatan yang pernah dilakukan dan berkas-berkas sebelumnya. Setelah itu akan melakukan pemasangan IV line. Nanti setelah selesai pemasangan IV line, perawat dan juga pasien akan mengunjungi poli jantung. Di sana akan dilakukan pemasangan EKG, dilakukan persiapan untuk treadmill, dan dilakukan tindakan treadmillnya. Sebagai perawat, yang kita lakukan adalah untuk mendokumentasikan waktu stake dari treadmillnya, terus presentasi pompa jantungnya, tekanan darah, nadi per stake, dan keterangan lain seperti keluhan pasien selama tindakan treadmill. Nah, setelah itu, setelah si presentasi dari pompa jantungnya telah mencapai 85% atau lebih, perawat akan melakukan penyuntikan dari radiofarmaka sendiri. Untuk MRCC kita menggunakan itu radiofarmakanya TCMIB. Mungkin di tempat lain juga sama. Terus setelah obatnya masuk, akan dilakukan jeda kurang lebih 45 menit dan lalu dilakukan scan. Selama 45 menit diharapkan pasien dan diusahakan pasien itu makan atau minum yang mengandung tinggi lemak. Nah, setelah 10 menit dari tindakan SPM biasa dilakukan tekanan darah atau TTV observasi. Kemudian next. Yang kedua itu dengan stress test dengan adenosin. Untuk adenosin sendiri dia tidak ada persiapan khusus, jadi pasien bisa datang aja. Tapi ada hal yang harus diperhatikan dari pasiennya, apakah dia ada riwayat asma. Karena adenosin cukup beresiko untuk pasien-pasien asma. Yang pertama dilakukan itu sama, pasien akan dipasang EKG dan IV line, terus kemudian obat adenosin sendiri akan diberikan kepada pasien melalui IV line kurang lebih 6 menit. Nanti untuk obatnya akan dimasukkan di 5 menit. Sebenarnya menurut jurnal itu 3-5 menit itu boleh, tapi untuk yang sering dikerjakan di sana itu setelah 5 menit obatnya dimasukkan, obat radiofarmaka atau TCMIB-nya dimasukkan. Dalam kondisi si adenosinnya masih tak berjalan, jadi nggak di stop di 5 menit stop dimasukin, enggak, tapi tetap berjalan sekalian dimasukin si TCMIB-nya. Terus yang sama juga yang dikomentasikan itu adalah waktu, tekanan darah per 3 menit, sama nadinya per menit, sama keterangan lain itu seperti keluhan-keluhan pasiennya. Dan sama setelah obatnya dimasukin, si TCMIB-nya dimasukin, ditunggu 45 menit kemudian baru dilakukan scan, dan selama 45 menit tetap sama minum makan tinggi lemak. Nah, selanjutnya untuk stress test dengan dobutamin sendiri ini ini pernah dilakukan tapi cukup jarang dipakai di sana karena resikonya lumayan katanya. Untuk dobutamin sendiri kurang lebih hampir sama dengan stress test latihan fisik karena sama-sama meningkatkan pompa jantung. Sementara kalau adenosin tadi itu dia melebarkan pembuluh darah. Untuk dobutamin itu sama, persiapannya sama, pasien harus stop dulu obat-obatan beta blocker dan golongan nitrat, stop kafein, terus sama juga untuk tindakannya pasang EKG, IV line. Cuman untuk perbedaannya itu kalau untuk dobutamin itu ada yang namanya naik dosis per 3 menit, dosisnya itu akan naik di kelipatan 5, 10, 20, 30, 40. Tapi maksimal dosis yang masuk itu adalah 40 sampai 50 mcg per kilogram berat badan. Dan sama juga dengan latihan fisik, bila presentasi jantungnya sudah 85% atau lebih, baru TCMIB-nya dimasukkan dan menunggu 45 menit lagi baru dilakukan scan. Selama 45 menit jangan lupa makan minum yang tinggi lemak. Kemudian untuk sharing tindakan SPM-nya hanya yang 3 itu aja saja. Sekarang kita mulai masuk apa sih sebenarnya peran perawat dalam tindakan SPM. Yang pertama itu bagian edukasi. Sebelum kita melakukan tindakan, sebelum pasiennya datang ke rumah sakit, kita harus melakukan edukasi terlebih dahulu. Apa aja sih yang diedukasi? Yang pertama itu stop obat-obatan seperti yang tadi golongan beta blocker dan kafein. Terus membawa 2 kotak susu putih full cream 250 ml dan mengedukasi tentang prosedur tindakan stress testnya. Lanjut. Nah, untuk perawat pada saat pelaksanaan stress test, apa saja sih yang dilakukan perawat? Yaitu melakukan pengkajian tentang riwayat penyakit dari pasiennya, tentang pengobatan jantung pasiennya dan keluhan pasien yang ada pada saat itu. Terus kemudian melakukan pemasangan IV line, dan memberikan dukungan psikologi dan atau motivasi yang positif kepada pasien. Karena ada beberapa pasien yang datang dia udah takut duluan dengan kata nuklir. Jadi kita perlu mengedukasi bahwa nuklir yang kita gunakan itu tidak berbahaya. Terus memasang EKG dan memperhatikan kenyamanan pasien selama tindakan SPM berlangsung. Setelah itu melakukan dokumentasi dan perhatikan obat-obatan yang kita gunakan itu ada dampak alergi nggak kepada pasiennya. Kalau misalkan ada, itu harus benar-benar diberhentikan atau didiskusikan lagi sama dokter SPKN-nya dan juga dokter spesialis jantungnya. Kemudian kita yang akan melakukan penyuntikan TSMIB-nya dan melepas apa-apa yang udah kita pasang, EKG, IV line dan sebagainya, dan melakukan TTV secara rutin. Kemudian nah, untuk post stress test sendiri yang perlu kita edukasi ke pasiennya itu adalah pada saat pasien buang air kecil pastikan tidak berceceran kemana-mana karena di urinnya udah ada radio nuklirnya sendiri dan disiram kalau boleh 2-3 kali sampai bersih, dan edukasi pasien untuk minum banyak air putih sehingga pengeluaran si nuklirnya lebih cepat dari dalam tubuh. Next. Terus tantangan apa saja sih selama stress test yang mungkin bisa terjadi? Yang pertama itu ketika pasien sudah di treadmill ataupun dia udah pakai dobutamin tapi si presentasi jantungnya itu tidak mencapai 85%. Bila hal itu terjadi, maka cara yang paling cepat yang mungkin bisa dilakukan adalah ganti dengan penggunaan adenosin. Tentu saja itu harus dengan persetujuan spesialis jantung dan juga spesialis kedokteran nuklirnya sendiri. Terus dengan pasien batasan cairan, seperti yang sudah saya jelaskan tadi, pasien harus minum susu kurang lebih 2 kotak pada saat menunggu untuk scan. Bila misalkan nih dia batasan cairan, maka susunya itu akan diganti dengan makanan yang tinggi lemak. Terus untuk pasien dengan kasus lupa stop obat-obatan pada pasien dengan latihan fisik, ini disarankan di reschedule saja karena akan susah untuk mencapai 85% tersebut. Beberapa dokter mungkin akan ganti dengan adenosin, tapi tetap kita harus izin kepada dokter pengirim. Jangan sampai kita ganti sembarangan sementara dokter pengirimnya maunya pakai latihan fisik. Next. Terus bila pasien sesak. Bila sesak itu biasanya langsung hal pertama sebagai perawat yang kita lakukan adalah memberikan terapi oksigen. Kemudian setelah itu masukkan radiofarmakanya. Kenapa dimasukkan sementara belum tercapai? Karena sesak itu pun merupakan respon tubuh maksimal dalam pemompaan jantung. Dan yang terakhir itu alergi susu atau adia pantangan lemak. Untuk pasien-pasien yang alergi susu atau pantangan lemak, biasanya kita sarankan untuk banyak minum air putih sebelum di-scan. Kenapa harus minum air putih? Karena kalau misalkan beberapa udah pernah ngelakuin SPM, pasti paham kenapa pasiennya itu diberikan tinggi lemak, kenapa harus banget gitu, kenapa nggak usah gitu, karena itu hubungannya dengan penangkapan si TSMIB-nya pada jantung dan juga pada hati itu ikut menangkap. Jadi kalau misalkan mungkin kita pernah dengar orang si radiographer ngobrol gitu tentang SPM ini, karena kan kita tahu radiasi itu dia itu seperti bintang cahaya gitu. Jadi kalau misalkan ada yang cahaya lebih terang, ada cahaya yang lebih terang, jadi bias gitu. Jadi nggak tahu ini batasnya di mana, batas jantung itu sampai mana, batas hati itu sampai mana. Kalau misalkan dipaksain untuk scan, dokternya kasihan juga mau bacanya, dia bingung ini sebenarnya cahaya dari mana gitu, ini warna dari mana. Jadi kenapa bisa kalau misalkan susu kan yang tinggi lemak kan dia kan karena ada proses pemecahan lemak dari jadi empedu hati dan semuanya itu kan melakukan sekresi, akhirnya paparan yang ditangkap di hati pun menurun, jadi si jantungnya lebih kelihatan jelas. Tapi kenapa bisa air gitu? Kalau untuk air sendiri karena jantung dan hati itu dan juga empedu dan segala macam itu di tengah-tengahnya itu ada yang dinamakan lambung. Nanti ketika lambungnya itu membengkak, diusahakan membengkakkan lambung semaksimal mungkin. Jadi kayak ada space gitu pada saat di scan, ada space yang kelihatan. Walaupun memang sama-sama terang, tapi karena udah terdorong sama si lambung, hatinya terdorong ke sana, si jantungnya agak naik gitu. Jadi kelihatan dokter itu mempermudah spesialis kedokteran nuklirnya untuk melakukan pembacaan hasil SPM. Baik teman-teman, sekian kayaknya. Sekian presentasi yang boleh saya berikan. Terima kasih.
Terima kasih untuk Mbak Yunice atas materinya yang sangat luar biasa. Sambil mempersiapkan untuk materi yang kedua, apakah ada yang ingin bertanya? Boleh? Banyak sekali penggemarnya Mbak Keke ini ya, Mbak Yunice. Boleh silakan, Mbak.
Assalamualaikum warahmatullahi wabarakatuh. Saya tertarik dengan penggunaan air. Ya, ketepatan kami nggak pernah pakai. Nah, pertanyaan pertama itu tadi, bagaimana sih mekanismenya sehingga air itu bisa, apakah hanya kita mengharapkan dorongan lambung saja itu sudah cukup gitu? Bagaimana hasilnya selama ini? Ada nggak kira-kira contoh hasilnya? Atau kalaupun tidak ada, bagaimana pengalamannya dengan hasil pemberian air? Dan apakah itu memang dicoba sendiri oleh bagian KN-nya MRCC atau memang ada risetnya? Ya, mungkin itu yang saya pertanyakan terkait itu. Karena kan bicara air juga, pasien jantung kita hindarkan pemberian banyak air, ya kan? Sementara di sini kita berikan banyak air. Ini kan jadi sebuah hal yang kontroversial. Itu. Kemudian itu yang pertama. Yang kedua, pernah nggak ketemu pasien pemeriksaan SPM tapi hasilnya gagal? Kira-kira apa penyebabnya gitu? Karena kalau kami selama ini sering terjadi dan kami bingung, ya kan? Kami masih mencari penyebab utamanya apa sebenarnya ketika gagal melakukan pemeriksaan SPM, hasilnya itu ya fotonya tidak optimal begitu. Pernah nggak? Terima kasih.
Baik, terima kasih untuk pertanyaannya. Untuk air sendiri, untuk jurnalnya ada, tapi ya itulah nggak ada di sini. Jadi untuk air sendiri itu sebenarnya kita pernah lakukan di sana dan mungkin itu sering karena beberapa pasien bukan karena dia ada pantangan atau apapun, tapi karena lupa bawa susu. Aduh, suster lupa bawa susu gimana ya gitu. Atau pasien memang nggak suka, maaf suster saya alergi susu begitu. Terus kalau misalkan mau cari makanan lemak kan lumayan tuh, 45 menit dia harus cari resto dulu, itu lumayan. Jadi kita memang penggunaan air ini sering di sana. Dan untuk gambarnya sendiri memang mungkin akan lebih sedikit, bukan mungkin, tapi memang dokternya sendiri pun mengakui itu lebih sedikit sulit dibaca dibandingkan yang udah pakai susu dan tinggi lemak. Tapi sejauh ini bisa gitu, bisa dibaca. Jadi sebenarnya dia itu hanya memang mendorong, jadi ada pemisah gitu antara si jantungnya sama bagian organ hatinya gitu. Karena kan bahkan kalau minum susu sendiri pun nggak akan ada pengurangan penangkapan radiasi di jantung. Jadi sama aja hatinya yang berkurang sama empedu dan semua yang ada di situ. Jadi kayak memang cuman mau dipisah aja, kayak memang nggak boleh bersama, harus pisah, udah gitu. Jadi memang dipisah gitu. Jadi dari yang dipisah itu dokternya bakalan ngelihat kalau memang ya ini jantung dan ini hati. Karena kan kalau misalkan hasil SPM itu kan dia di slice gini kan ya, ini jantung di set gitu, bukan yang begini-begini. Nah, jadi dokternya ngelihatnya dari situ, dan itu juga radiografernya pun mungkin akan pada saat ngasih gambarnya ke dokternya, mereka akan atur biar hatinya nggak terlihat sangat banyak dibandingkan jantungnya. Terus pertanyaan yang berikutnya tadi, boleh Kak? Apa tadi? Oh, untuk gagal sendiri sebenarnya sejauh ini kayaknya baru satu kali, dan itu balik lagi, ini kan tadi Bapak bilang ada yang gagal sering gitu, tapi kita balik lagi nih, ini gagal seringnya itu dia penggunaan latihan fisik kah atau farmakologi? Baik, sebentar saya jelaskan untuk yang gagal dulu ya. Kalau untuk yang gagal sendiri ini, itu dikarenakan penggunaan dengan adenosin, dan adenosin itu pada saat dia masukin si TCMIB-nya, adenosinnya itu sempat diberhentikan gitu. Dia masih kocek-kocek kayak masih gabungin ke IV lainnya, tapi dia udah berhentiin adenosinnya. Sementara adenosin kan cepat banget hilang efek sampingnya. Jadi karena itu jadinya kayak kurang jelas gitu gambarnya menurut dokternya, dan dilakukan pengulangan berikutnya itu tak berhasil. Untuk ISDN sendiri, mohon maaf Pak, ISDN itu bukan bagian dari sidik perfusi miokard, dia itu masuk ke viability. Jadi kalau misalkan mau dijawab bukan bagian saya. Benar.
Maksud saya kadang juga yang stresnya sendiri ya,
Biar ganteng berdiri.
Duduk nggak enak kan?
Boleh?
Nah, jadi walaupun itu tadi dipisahin kan uji viabilitas sebenarnya ISDN.
Viability.
Tetapi kadang yang diaresnya juga yang tidak diberikan apa-apa, itu hasilnya juga gagal. Itu yang menjadi pertanyaan kami, apa sebenarnya penyebabnya gitu.
Oh.
Jadi bukan hanya dengan ISDN, tapi yang tanpa pemberian apapun itu juga kadang gagal.
Kalau mesin speknya tapi aman. Karena pernah juga karena salah tekan-tekan radiografernya. Jadi dokternya kayak, ini kenapa gambarnya gini sih gitu?
Enggak. Sementara hasil QC farmakanya itu bagus. Itu yang kami juga sekarang bertanya-tanya.
Mungkin nanti ini kita bisa Bang, nanti kita bisa langsung tanya sama Dokter Pushan karena kayaknya dia yang lebih expert dalam hal ini. Nanti boleh kita skip dulu sementara. Kayaknya kita langsung ke expertnya aja lebih karena kan kita juga di lapangan juga bersama-sama. Oke, welcome Dokter Pushan. Thank you Mbak Indonesia. The second speaker Dokter Pushan.
Yeah, thanks the organizer for first of all inviting me to talk, and number two to make these changes because I was still on my way. I just arrived today, in fact half an hour ago to Samarinda. I missed my flight from London. Anyway, so I'm a consultant in nuclear medicine and PET at the Royal Brompton and Harefield hospitals. We have actually 3 sites, and the reason I'm saying is that at different sites we have different modalities of stress which are more popular. We have at Royal Brompton, and then Harefield Hospital, and we have a PET center in the city center which is only doing rubidium rest stress. So we have different modalities of stress that we perform. So the outline will be the principle of cardiovascular stress. We'll talk briefly about exercise test and then inotropic stress with dobutamine and the 3 different types of vasodilator stress. And we also talk about what is the best combination form. So if you look at this, on the left you have got 2 modalities of stress. It's either physical stress or pharmacologic stress. So what happens is, why do we need to stress the patients? Because the resting blood flow does not indicate coronary artery disease. Because even with up to 85-90% stenosis, a resting scan may be normal, and therefore we need to do the stress. We loosely use the term stress, but if you think about in vasodilator stress, what happens is we give a hyperemic response. So an abnormal vessel is already dilated and exhausted its dilatory reserve. So it does not open up, but a normal vessel will open up by 4 to 5 times its capacity. So you can imagine what you are doing is a flow heterogeneity. You are creating a flow heterogeneity. And at that point, when you inject the radioisotope, it will distribute proportional to the flow at that point. And that's how we get these perfusion defects. So here is a case of a proximal RCA disease. The patient had an inferior stress defect, which is almost reversible at rest, and we call it inducible ischemia. And as you can see that the resting blood flow goes down only significantly after 80-85% stenosis. So the dynamic exercise, anyone who does dynamic exercise regularly for cardiac stress? I would guess most of you would attempt, or in fact, before I go ahead, I would like to know who amongst you offer pharmacologic stress by default? All pharmacologic stress? No. Selected, yeah, okay. That's how it should be. You should be selecting your patients, but there are centers, including one of my centers at Royal Brompton, we use regadenoson as a default stress. But in Harefield, we do depending on the patient and depending on that. So the pros, you know, physiological, cheap, reproducible symptoms. We have plenty of prognostic information and guidelines. Usually they prefer stress, and generally you have experienced that patients who exercise have got better quality images in myocardial perfusion imaging. But if you think about it, most of the patients who come to nuclear medicine, by that time, the cardiologists would already know what is their exercise capacity and other things. They send the patients to nuclear medicine for some very specific reason, and therefore there are some sort of controversies as to what you should be offering. Yes, if a patient is young, it is diagnostic, and there has been no other test before, it is definitely the test of choice. But a patient with known coronary artery disease, infarction in the past, angioplasty in the past, you have one particular question, pharmacologic stress probably is better. And there are many cons. You know that ECG changes are inaccurate, ECG often is uninterpretable. Some of the ECGs are contraindications, for example, left bundle branch block. And it is difficult for these to be combined with stress echo, impossible for MRI. And most of the patients who are exercised, they end up in having a submaximal exercise. That I think most of you would have experienced. And when you start, a patient exercises for 5 minutes, the doctor is very reluctant to cancel the exercise. So they would probably inject when the patient has not achieved the target or has achieved the target far too soon. For example, someone who is completely deconditioned, if you make the patient exercise on a treadmill, he may reach the target heart rate within 3 minutes. The question is, should you inject at that point? No. My working principle is the patients must be able to exercise for at least 6 minutes in Bruce before we inject. If they cannot, then transfer to others. So this is the study which shows that there is a significant reduction in sensitivity if you are combining submaximal exercise versus maximal. And this is something which we nuclear medicine physicians already know. If a patient has left bundle branch block and if they're exercised, if their heart rate is high at the time of injection, we can see false positive defects, septal defects, because that is because of the septal asynchrony. And therefore, it must not be offered to patients with LBBB. So let's start with this one. Anyone who has experience of using dobutamine for myocardial perfusion scan? Can I have a raise of hands? One? Any more? I find dobutamine is being very rarely used. People are sort of scared with it, dobutamine. But yeah, it's not as good as the vasodilator one, but in certain patients, dobutamine becomes a kind of an imperative. For example, at Brompton Hospital, we do a lot of lung volume reduction surgery in patients with extensive COPD, and these patients cannot be stressed with any of the vasodilator drugs. We are even scared to do regadenoson, because if there is some bronchospasm, regadenoson does not produce this, but if it does, then these patients can go to type 2 respiratory failure. And they tolerate dobutamine pretty well. So dobutamine, as you know, it's a synthetic analog of dopamine, and it's got a half-life of 2 minutes. And we do it incrementally, starting from either 5 to 10 micrograms per kg per minute, increase it by 10 every 3 minutes, and at the end of 40 micrograms per kg per minute, if we still do not get the response, we can top it up with up to 1.2 milligrams of atropine. And another thing, this is a personal advice or a tip, if you can say, if you are using dobutamine, be careful at the 30 and the 40 micrograms kg per minute rate. What I often do, if the patient's heart rate is steadily rising at the end of 30, let's say, I do not go to the 40 stage. I just wait for that stage till I see a plateauing of the heart rate response. Because if the heart rate is rising, you don't need to go to the next stage. You can continue with that stage and get the response and inject. So that's one thing which we routinely do at 20 and 30 micrograms. If heart rate is rising, do not go to the... But the problem of dobutamine is that there are some serious contraindications, as you can see. Any recent acute cardiac event, any arrhythmia, uncontrolled hypertension, or any patients with basically who is hemodynamically unstable, patients with severe left ventricular dysfunction, I would never use dobutamine. Vasodilators are, strictly speaking, much safer than dobutamine because of the nature of their action. And what I was explaining, that we call them vasodilator stress, but strictly speaking, they do not produce stress really. They cause a flow heterogeneity, as I explained. And because of that, stress test with vasodilator agents is much safer than with dobutamine or with physical exercise. There are three, adenosine, dipyridamole, and regadenoson. Anyone using reg in this room? Don't have in Indonesia. So your default is either dipyridamole or adenosine, or is it routinely adenosine now? Okay, that's good. Because dipyridamole, the main attraction was it was cheap. When I was in Scotland in my first tenure, we used to use dipyridamole because it was cheap, basically next to nothing. But dipyridamole has a problem of lingering side effects and ideally should be given an antidote for almost all patients. So that's good to know. Adenosine. Now, there are a few complicated things in the adenosine pharmacology. I will always encourage you to read up. Essentially, summary, there are three types of adenosine receptors, A1, A2, and A3. And A2A is the particular subtype which is responsible for vasodilation. And the rest of the things produces what we call side effects. For example, the A1 receptor produces slowing of the heart rate, the A2B and the A3, they are responsible for bronchoconstriction, peripheral vasodilation, and all these things I do not want. I just want the central three things, coronary vasodilation, that of course will produce some sympathetic stimulation. And therefore, regadenoson, which is a selective A2A agonist, is the preferred agent of choice. With the adenosine protocol, because you are using it, you know, it's sandwiched between the entire infusion. So continue the infusion for 3 minutes, inject the adenosine, and then continue it for 3 minutes. If the patient is having serious side effects from 2 minutes, we often used to truncate the protocol. There can be different truncated protocols, all have been published and kind of validated and are equally effective, but injecting at 2.5 minutes and continuing the vasodilation for 2 more minutes. So the truncated protocol in a patient who starts showing side effects at 2 minutes, you can inject at 2.5 and continue the infusion till 4.5 minutes instead of the full 6 minutes, and that should be sufficient. Because if you maintain the vasodilation for 2 minutes after the tracer injection, I think your purpose is served. And it is, amongst you, who combines adenosine with physical exercise? Anyone? Usually it is not because of the nature of the infusion, but if you have a setup like this, what you see here, at Brompton, we have an upright bicycle with which we combine adenosine if we have to. Our default is reg, but for adenosine, we also put the patients on the bike and they do some exercise. It is difficult to make the patient exercise on a bike, but whatever, even if the patient does not do any physical exercise, this is a must. You must combine isometric exercise, and especially patients with borderline blood pressure, borderline heart rate around 50, 55. If you combine isometric exercise and the patient does not have rheumatoid arthritis fingers, you will be able to increase the heart rate by up to 20-25 beats per minute easily if they do it well. So do not forget to combine isometric exercise with adenosine. The slides are, because these slides was made in a longer format, so they are kind of cutting out from here and there. So these are the things that you already know. There is a drop in systolic pressure, drop in diastolic blood pressure, and there is a slight increase in heart rate. With dipyridamole, as I said, the main problem is the lingering side effects, but good that nobody does it anymore, so you don't have to be worried about things. This is mostly of historical importance. But we found quite a few interesting things, that dipyridamole patients are fine in the stress room. They go out of the stress room and they start having a kind of a semi-collapse kind of a thing, just because of lingering side effects. And what we routinely did was inject 125 milligrams of aminophylline before they left the stress room. And if the patients would be driving long distance, this was my experience in Scotland, we did an audit for patients who were stressed with dipyridamole, and many of them complained that they felt quite unwell for up to 6 to 8 hours, and many of them had to drive back. So our protocol was 125 before leaving the stress room, another 125 before they left the department. And so you give it for 4 minutes and then wait for 3 to 4 minutes before you inject. So that's the problem. It's a long half-life. but the main attraction was its cost. And regadenoson, which is highly selective because it is a selective A2A agonist, and basically it gives you what you want and it does not give you what you don't want, which is nice. But the interesting thing, I'll show you some examples, like when we think that they won't give you certain side effects, but actually they do. We do not know sometimes how they do it. But essentially, it has got very weak, if any, affinity for A2B and A3 receptors. The attraction for regadenoson is that, yeah, although it is very expensive to start with, but it saves cost in many different ways. For example, this is an injection which is a one-shot vial for everyone. One fits all. You know, not XL, large, small, medium, large. No, just one. One injection, whether it's a 40 kg woman or it's a 120 kg man, that's an attraction. So you don't have to set it up. You just draw it up on a syringe and push it. That's the biggest advantage. And so it is given for 10 seconds, and then there is a flush. And you give the injection, then you can inject the radioactivity. So what we do is combine physical exercise routinely with it. So the patients go onto a treadmill, they walk for 2 minutes, and when they're fine, then we give the regadenoson infusion, just injection for 10 seconds, and then 10 seconds later we give the radioactivity, and they continue exercise for another couple of minutes. I will talk about a modified protocol at the end of the talk. So basically the reg protocol is complete within 1 minute. Generally speaking, the antidote aminoflin is not required, and there is a little bit of reluctance of giving aminoflin with regadenoson across many centers in UK. I've spoken to many consultants. There's one scare of seizures, because generally speaking, as you know, patients who are injected, who are stressed with regadenoson can actually lower the seizure threshold in certain sensitive individuals, and aminoflin has got the same tendency. So combining regadenoson with aminoflin, you must be making sure that the patient does not have any history of epilepsy. Even if it is treated, you should not use this combination at all. And this is a very standard hemodynamic response. The heart rate goes up significantly. If it does not, then we start suspecting something. And systolic blood pressure goes down slightly. Let us escape this one. So when I came across the third phase trial studies of regadenoson, I was very surprised, because when you think about it, it's a selective agonist and you would expect there should be no side effects. But if you look at the vis-a-vis comparison of side effects between adenosine and regadenoson, you can see that most of the side effects are there. And most disturbingly, what you would expect to be minimal is the breathlessness. And if you see the graph, 34% had dyspnea on adenosine and 36% had. So basically no difference in dyspnea. And how do you think you can explain it? We know that this is not causing vasoconstriction. But other side effects, there are some relative, more or less. For example, chest pain is much more common with adenosine. It is less common with dipyridamole, with regadenoson. Generally, abdominal discomfort, I find it's the same. One thing which I find more patients complaining of is a general lightheadedness or dizziness following regadenoson. And headache is also probably mildly more common in reg. And there are some reports of spurious diarrhea following regadenoson infusion in some individuals, where we do not have any explanations, but most centers who are using it for quite a while, they will all tell you, yes, there have been some patients. So what is the cause of this breathlessness? We'll visit that. Most of the cautions that apply are the same for any pharmacologic stress with vasodilators, caffeine avoidance for 12 hours. But if a patient has recent MI, then you have to be careful. And mind you, although the side effects of heart block or bronchoconstriction is less with regadenoson, it is still, you have to be careful in patients with recent coronary syndromes or patients with severe asthma. Mild to moderate asthma, regadenoson is fine, but if the patient has severe asthma, think of dobutamine. And as I said, the combination with exercise, which is often done, has to be carefully done if there are symptoms or signs of myocardial ischemia. And important thing is that it can lower the seizure threshold in sensitive individuals or patients with previous history of epilepsy or recent stroke. And aminophylline is also a proconvulsant, so the combination can be a little tricky. And these are the things that we are trying to now explore. What is the reason why the incidence of breathlessness is the same as in adenosine? So there have been many trials which are quite nicely designed, well-controlled trials where they're double-blind, placebo-controlled, and crossover designs where patients with mild to moderate asthma have been stressed with regadenoson versus placebo. And what we see that although patients, there was no difference in the FEV1 post-stress versus FEV1 baseline between the patients who complained of dyspnea and those who did not, which is interesting. And similarly, patients between placebo and regadenoson, if anything, the FEV1 post-stress was slightly more in the patients who were stressed with reg than placebo. So obviously something is happening here which cannot be explained by FEV1 because that's the indicator of bronchospasm. And in same thing has been reproduced in patients with the COPD, that we found that there is no difference in FEV1 or the forced vital capacity post-stress between patients who have been either stressed with regadenoson or placebo. So the effect probably is happening at some other level that we are not aware of. Safety-wise, this is, I think, most of you, anyone has come across a serious side effect, incident following a pharmacologic stress? What have you come across? What's the worst have you come across? Anyone? Heart attack? Collapse, ventricular fibrillation, ventricular tachycardia. I had one patient with VT. Fortunately, he was not, he was asymptomatic VT. The VT was noticed on the monitor. And another patient had gone into acute left ventricular failure. This patient had an ejection fraction of 35%, and we had no other choice than to stress him with dobutamine. And this patient went into LVF, but he was managed immediately. That's the two worst things that I have come across. So generally, the bottom line is pharmacologic stress, especially with the vasodilator stress, is extremely safe. And because there was a nurse-led talk, I thought I'll include this slide. We had done an audit of the nurse-led versus doctor-led stress sessions at the Brompton Hospital many years ago. This was data from 2002, where we found that there is no significant difference in the patient's outcome, whether it is bronchospasm, fatal myocardial infarction, chest pain, or transient heart block between. And in fact, in my experience, when I moved to Scotland, we had introduced the nurse-led cardiac stress services, and it went perfectly well. As long as everyone in the team is on the same page, I think it works perfectly well. If anything, my experience that the nurses are probably more thorough than the doctors, because the doctors think about the big things and forget about some of the smaller things, but the nurses are usually more meticulous than us. So it works very well. And as I said, vasodilators should be combined with some form of stress. If you have a bicycle, that's perfect to combine with adenosine. Again, patient permission provided. I think the patient probably has passed away. This is a photograph from the 90s when I was a registrar at Royal Brompton Hospital. and these are the common findings. When exercise is combined with adenosine, the side effects are much less. Number one, of course, with exercise, they are cancelling the hypotensive effect, cancelling the bradycardic effect, and also because the patient is more occupied, mentally occupied with the exercise, they feel less of the side effects. So this is known that especially the flushing is significantly less when the patients are exercising than they are not. And as I said, even if they're not exercising, do offer them isometric exercise, it helps. And if they don't do exercise, this is what happens. The splanchnic circulation is intense. So what you want is nothing below the heart, as little as possible, and therefore any kind of physical exercise will divert the excess of the radiopharmaceutical into the skeletal muscles, into the peripheral muscles, and you have a much clearer chest to look at. And ANM has suggested that you combine exercise, and with regadenoson, the advantage is that, as I said, you can seamlessly transform a physical stress into a pharmacologic stress without even having to let the patient leave the room. So you make the patient exercise, you think the patient is not able to achieve the target, you just drop the reg and push it, and it works. Whether it works or not, they have done studies. I'll show you one. How am I doing in terms of time? I'm okay? Okay, brilliant. So we start the test, regadenoson given at 1.5 minutes, tracer injected at 2 minutes, and then this is the usual protocol that at low level the patients continue to exercise. In fact, the longer the better, as you can imagine. And the patients also get a lot of confidence if they're able to walk even at a slow rate. Once they're doing nothing, just lying on the couch, the apprehension, anxiety, everything becomes much more. And generally we would like to wait till the heart rate goes below 100 and then stop monitoring at that stage. So this was the thing which they had looked at, whether, and this was published as a trial. So essentially the patients were started on a treadmill test, and if they were unable to achieve the 85% maximal predicted heart rate, they were randomized to regadenoson either on the same day, means they continue to run and doing it, or 1 hour later on the same day, or bring them back on another day, which were labeled as MPS 1 or MPS 2. And the outcome was, of course, the reading of the scans by 3 readers between MPS 1 and 2, and they found that there is no difference between the techniques in terms of the images, so provides comparable detection of inducible perfusion abnormalities. Both are equally well tolerated, improved heart to background ratios by exercising, but as I said, if you start noticing that the patient is having signs of ischemia, chest pain with ECG changes, definitely be careful with reg. So in conclusion, pharmacologic stress is an essential component for cardiac imaging, as most of you would now appreciate. Regadenoson stress has increased the flexibility for MPS and stress MRI. And the thing which I said, which is the most important thing, that you can start a physical exercise and seamlessly end into pharmacologic exercise if the patient is unable to continue. And this is our default form of stress at the Royal Brompton Hospital. At Harefield Hospital, we do what most of you do, is depending on the case. But generally, another piece of advice is because you are doing adenosine, I think it does not apply to you, but generally, patients who are very vulnerable, for example, extreme age, patients above 85, patients with LV dysfunction, patients who generally appear to be frail, we would prefer adenosine simply because the side effects are quickly reversible. So that is our only reason for going to adenosine versus regadenoson. And as I said, it can be readily combined with dynamic exercise if fact, I can't even read what I've written because of the format. But yeah, so that is the summary of pharmacologic stressing and physical exercise combined with myocardial perfusion imaging. Another thing which I wanted to ask again, can have a show of hands. Anyone who does a rest stress protocol in your department? Or everyone does a stress rest protocol? Stress rest? Yeah, mostly. And when do you do a rest stress? Not good. Yeah, which is again a sensible thing because you want to see how is the resting perfusion. If it is too bad, then you won't stress. And sometimes we don't have information. The reason I'm asking is when you are combining it with myocardial perfusion scanning with PET, you don't have a choice. It has to be a rest followed by a stress, and there is slightly different preparation before the rubidium rest is because obviously you're not going to combine any exercise, not even isometric exercise, because you are quantifying, you do not want any movement at all. So what we do is, patients of course, they come fasting, caffeine free, etc. We also give them a bit of fizzy water or at least some water to distend the stomach a little bit, because this is our experience. If the stomach is at least distended reasonably, the stomach-related activity does not interfere with the images. Otherwise, it can be extremely tricky if you've got a hot stomach sitting under the rubidium scan. So that's the combination of pharmacologic stress with myocardial perfusion with PET. Any questions?
Satu pertanyaan untuk Dr. Pushan. Ada yang ingin bertanya?
Feel free. I think the whole purpose is basically the dialogues rather than the talk, because what I showed on the slides, everyone knows. It's more like the personal interactions.
Any questions for Dr. Pushan?
If not, can I ask, sister? You delivered the talk on nurse-led stress sessions. No, I was interested to know what is, do you have any structured training across the country for the nurse-led stress sessions, or is it more informal?
So the nurse training is usually not structured. Usually the nuclear medicine physician will train their nurse in the hospital. So in this the national setting like this, we just share our experience, the nurse especially. But if they have questions, actually they usually go to their doctors.
No, I think we all have gone through this process. Like when I was a registrar at Brompton in 1997, that time we had introduced this nurse-led session. There was no structuring, so it was exactly like this. But then gradually over a period of time, as more and more nurse-led, in fact, there are very few centers which are now insisting on doctor-led stressing, because simply there is not much time, because if a doctor has to spend the whole morning stressing, when does he report? In many centers, it's just single centers. So then at some point, it would be a good idea to form a structured curriculum, and implement it kind of a nationwide. Okay, if there are no more questions, thank you for your attention.
Thank you, Dr. Pushan, for sharing your insight and experience.
slides are all in horizontal format. Can we have a different screen? Because it's very difficult for me to show the images because I can't control this. This is 4:3 format, right? If you see on your screen, you will know what it is.
Untuk perwakilan dari perawat boleh untuk memakaikan shawl pada pembicara. Boleh Pak Sunoto boleh pastikan ke Dokter Pusen dan Mbak Keke. Thank you Dr. Pushan and Nurse Yunice. Dengan berakhirnya sesi Symposium 9, saya ucapkan terima kasih kepada para peserta dan para pembicara. Demikian saya tutup acara hari ini. Assalamualaikum warahmatullahi wabarakatuh. Ini akan dilanjutkan untuk SYMPO 12.